the studies that were interesting. So this is the one I had ended with at the last session, but we were literally at like 155. And so just to see if anybody actually has thoughts about this or how they're using it. So the question of what to do with archived genotypes. So this was a study presented at CROI. It analyzed people living with HIV, a total of 242 who had had viral suppression for 3 to 6 months and no prior failure on an INSTI regimen and no prior viral load greater than 400 copies. So they did genotyping with HIV or proviral on at least 2 pre-switch time points and 2 time points for 223 participants and more than 2 for 26. And so they had a couple different analyses here, some who only had 1 time point, some who had multiple. So they categorized them as the 2-point group they detected in 100% of the proviral genotypes or 50%. So let's say there's a K103N and you had 2 proviral genotypes, either you detected it both times or you detected it in one of them. Because, oh, sorry, my Zoom does these things and I have to figure out how to turn it off. And then for the multiple time points, they characterize it as persistent, as loss of detection, so you observe it and then you don't observe it, or as gain of detection, or just variable over the course of many proviral genotypes. And so what they found was that the 2 time point, they had 262 resistance-associated mutations and 4,000 non-resistant substitutions. So they were trying to use these as a control to say, like, okay, these are other polymorphisms in the virus. How consistently can we detect those that shouldn't necessarily feel pressure from drug? 39% of the resistance-associated mutations were detected both times. The 100% here is both times. And that means that almost a little more than 60% were detected only once out of the 2 times that the proviral genotype was done. So then the question is it that they were detected earlier? So these people are suppressed, right? So in theory, we always say, resistance is easier to detect closer to the time of drug exposure. So in the 50% detection group where you detected it 1 out of 2 times, did you detect it at the first time and then it went away at the second time? But actually, no. 64% were detected at time point 2. So that's basically random distribution. So there's no suggestion that over time you're losing proviral evidence of resistance in the way that we would predict that you would lose RNA or plasma virus evidence of resistance. Non-resistant substitutions were more stable. So they were 76% were detected all the time. But I will say that it's a much, much larger sample size. So they're up at 4,800. So there's a lot more sort of statistical play in terms of how robustly you need to demonstrate your ability to detect things. And the time difference, also again, at this decay question, was not that different. So if these, our ability to detect resistance mutations went away over time and space from the drug exposure, then you would predict that if it was a very, very long time between 2 time points, you would see a difference there, but it wasn't. So the 100% detection samples, so ones in which the K103N, for example, was seen both times, the median time between the 2 was 7.7 years. And in those where it was only detected half the time, the median time between the time points was 5.5 years. So in their multiple time point analysis, this is when they had lots of different proviral genotypes, 45% of them were variable, meaning detected at some times and not at others. 26% went from not detected to detected during a period of full suppression, and only 18% were detected at all time points, and about 9% were lost over time. So I would be interested to know how this makes people feel. This is like a lot of data, but basically it says that if you do a proviral genotype, you have about a 40% rate of finding that same mutation if you did the proviral genotype again. And I don't know exactly what this means in terms of how we interpret it and whether or not we should rely on it. The other piece of data about archived genotypes from CROI itself was the findings in the CARES study. So the CARES study, which we went over last time, was a sort of application of cabrylpivirine in sub-Saharan Africa, and it had overall good outcomes. And one of the surprising findings of the study was actually that there was a relatively high rate of rilpivirine resistance at baseline, despite overall good performance of the regimen. And so with that in mind, then the question is, what do we do with these things? So, and in the CARE study, the rilpivirine resistance mutations were done on proviral genotyping because it was a suppressed switch study. So we have now these two pieces of data that are emerging, one of which is that proviral resistance testing is very variable, and the other of which is that we have seen archived or proviral resistance in a population for which the cabrylpivirine regimen worked well. So those are sort of one side of the question. There's also a paper in AIDS from, I think, a year and a half ago that we've talked about at this meeting before that said that they more frequently identified mutations on non-intact proviruses. So suggesting that, you know, we have often said, if you see it there, you can believe it. This other paper, the paper in AIDS, which we've talked about previously, but I don't have slides about today, actually showed that they more frequently saw these mutations on viruses, proviruses that are already defective. So they weren't going to cause viremia. So that would be one reason why you could detect a mutation on a proviral genotype, but actually still do fine on a regimen that should be compromised. Now, all of that data, which basically says you can ignore proviral genotypes, has to be held in contrast to the randomized controlled trial data from Atlas and Flare, which I believe I misspelled Flare here, but regardless, that cabrylpivirine failure rate was actually impacted by what was proviral rilpivirine resistance testing. So in that study, they saw that having pre-existing rilpivirine mutations was linked to worse outcomes in individuals who switched to cabrylpivirine at that very low but present failure rate. So Joko, do you have thoughts and feelings?
I'm just so confused. I had used these a lot early on, and then I've learned to ignore them and not order them anymore because they were not particularly helpful, to be quite honest. And then, as you say, the cabrylpivirine study came up, and I thought, well, at least maybe for those patients, I might be getting them, but I don't do a lot of them anymore. I'm curious what others do.
Yeah, I'd love to see if people want to put in the chat or, and I'll just also put in one other piece of data. There was the abstract presented at IAS where they looked at dolutegravir 3TC in people with a known history of an M184V. It was documented in their charts. It had been previously done in a regular standard genotype, and they did baseline proviral testing in those patients, and they detected them, I think, in 30%. So again, you can't always see it, even if you know, like for sure, that it was there at some point. And then sometimes you see things, and you're sort of like there in the cabrylpivirine, in the CARE study, there was a baseline rate of integrase resistance in that study, which is surprising. They were a fully suppressed population. And so I would have to say, Joe, I think I use it similarly to you, which is that if someone's going on cabrylpivirine, I feel a little bit nervous about it. Some unknown portions of their history, some periods where maybe they weren't really that well engaged, and a little bit of uncertainty about full adherence. And or also, I just don't think they're a perfect candidate, and I'm looking for another reason why. I might do it in that setting. I think I have also have certainly looked at them when they're available for these complex resistance cases that we have, because I think there's some information there. But I don't know that I've ever been like, okay, the proviral genotype says this, we absolutely must do X or Y. Other people have thoughts or feelings?
Everyone's video is blocked. It makes it seem lonely in here.
It is lonely, Chuck. It is. It's not. It doesn't just seem that way. Maybe I'll just actually pick on Kristen Kilcrease if she's available to unmute. But just because you have been the funnel through which almost all cabrylpivirine referrals in the clinic, if not all, have gone, do you have a sense for how frequently we've looked at these, or how that has fed into decision making for patients?
I don't have like a frequency. I primarily use it kind of similar to how you and Joko use it. If I am concerned with a patient who has a gap in history, or I'm unclear of what their history has been, then I will send it. But if it's there, I'm definitely going to use it if there is, any RAMs that have shown up on it. I wouldn't say that I don't have an exact frequency, like I can't give you a proportion of patients, but I wouldn't say that I see a lot of providers sending them ahead of starting their patients on Cabenuva.
Okay, great. Well, if nobody has any other thoughts on this, I'll move to the next thing I was just going to cover briefly.
Can I say something?
Oh, please.
Something we had been talking about at BCHD was whether with new patients, we should more systematically do integrase on the genotypes instead of just PI and RT resistance, so that in the future, if someone did want to switch to cabopivirine, we didn't have to scratch our heads and wonder if we even needed a proviral. Something to think about.
And so are these patients with treatment experience who are coming in by remic?
Not necessarily, either new diagnoses or people transferring in by remic.
Yeah. So, I mean, I think it's a good question, right? And on the DHHS committee, that there is some work going on recommendations around genotyping and other resistance testing, and we're sort of sorting through what the actual data is. So historically, this has been because there was an up to 10% rate of NNRTI resistance primarily, so K103N, at the time when efavirenz was the first-line base regimen recommended for almost all people living with HIV. And so that was part of the reason for recommending baseline testing with a genotype. As far as integrase resistance, even with, I think, the most recent data I've seen, which was from a few years ago, and I should look to update this, the rates of integrase resistance were still on the order of 1%, transmitted integrase resistance. So you acquire a virus already with integrase resistance, so relatively low. In the United States, at least, that was a New York City-based study that I'm recalling, although I don't have the specific details. So with that level of resistance, it wasn't necessarily recommended to do baseline integrase resistance testing. I think the question about whether or not to do it is really based on whether or not we see a difference in transmitted or resistance at failure. And there was actually a whole session at CROI about dolutegravir-associated failure. And I mean, for me, I think the take home from that, and I'd be interested what others thought from that session, was that, when you have literally, I think, 20 million people currently on dolutegravir, lamivudine, tenofovir, you will have some treatment failures with resistance, right? Like, that's a lot of people, and there will be some that actually fail and actually do have resistance. How that feeds into like the sort of transmission patterns in other sites, like, so if people are coming from regions of high endemicity and also where everyone is on this regimen with HIV, should we be testing more in that setting than in others? I don't know the answer for sure. But I'd be interested to know if other people have started sending integrase resistance. Like in some health systems and at LabCorp, you don't have to make the decision because it's just included. It is still a separate step for us. I have not started doing it in new acquisitions but I do think, like Sarah, as you say, having a systematic approach probably seems like a good idea. All right, so I'll take that as homework to try and look more at, oh, go ahead, Sonia.
Oh, I was just going to say I don't do it, but I now have about 5 to 7 people with integrase resistance. And so I'm getting more and more anxious about it for new diagnoses, but I still don't do it yet.
Yes, although I think, Sonia, you're like cultivating a small garden of very challenging patients. So
Yes.
we should, the overall landscape may not be the same, but those were all heavily treatment experienced. Yeah.
Correct. Yeah. But, just like when I was a fellow, it was I kind of thought about dolutegravir similar to darunavir in terms of the barrier to resistance. And I am not feeling that way anymore.
So I think it is still true. It is a very high barrier. You do have to like actually have very specific practices in order to get integrase resistance, but it is not impossible. So I think that is And
Yes.
David is saying he doesn't do it, not for new diagnoses. And so I think for these heavily treatment experienced, but I think to your point, Sarah, the question is, if we have an opportunity to get a viremic genotype instead of a proviral genotype, should we take that opportunity?
Exactly.
Yeah. And I would kind of think yes. If in particular, if it's a person you think you may put onto cabrolpivirine because of adherence challenges. And again, I think the other challenge there is just like getting to that nice definition of who that candidate is, right? Because it's like one of these things, you know it when you see it, but it's hard to list the criteria. But I agree. I think that sounds like a really important thing to think about. And maybe just as general practice, all of Sonia's patients should have baseline integrase resistance testing at transfer of care. So I'll just switch to the next other thing I was going to highlight. So this is a paper from Rebecca Abelman, who's like a junior investigator at UCSF. I had the opportunity to meet her last year, and she's just really fantastic. I'm excited to see what she will do. But she's been doing a lot of work in the WISE cohort, and she looked at WISE data between 2006 to 2019 in non-pregnant virally suppressed women. 424 of them in that window switched to an INSTI with their index visit in that window, and 735 did not during a similar time window. And then they included 904 women without HIV as controls. So at the index visit, 28% were premenopausal, 10% were early peri, 28% were late peri, and 34% were post. And they used AMH and STRAW criteria for identifying those categories. And what they identified was that a switch to INSTI in late peri or post-menopause was associated with a significant increase in BMI and waist circumference. And so that's what's seen here on the left, is that this is reproduced from her abstract. So the INSTI negative is here, and the INSTI positive switch is in orange. The women without HIV are in gray. So if you're premenopausal switch, maybe a little bit more with INSTI, but not that much. If you're post-menopause or late perimenopause, so moving through menopause during the subsequent 60 months or longer, there's a very big difference in which is this orange line here, with a really substantial difference in waist circumference and also in weight gain with switch at that very moment, as compared to women without HIV and women with HIV who did not change to an INSTI-based regimen during this time. So about, in terms of the other factors that may be feeding into this, about 64% of those who switched to an INSTI were on TDF prior to the index visit, so probably were also switching to a TAF component, may have been switching to a TAF or a bacavir containing regimen during that time, and 78% of the INSTI negative were on TDF at the index visit, so they may have just continued on TDF. And so Yuka's asking if the late perimenopause control line seems too flat. I will say, so you want to unmute and say what you mean?
No, I just would have thought it would go up. I mean,
Yeah,
with
right.
weight, right? So like the fact that it does, nothing happens is a little funny to me.
Yeah, I mean, I think the women without HIV actually have this like slight decline. The women with HIV on an INSTI, without a switch to INSTI, who presumably may have been maintained on TDF, have a gain, but it's slower.
Yeah, I'm talking about the gray line, exactly.
Yeah, no, I agree, because my initial thought about this finding would be like, oh, welcome to perimenopause, but it doesn't look like that based on these data. And this is WISE, where they have like nice controls of women without HIV who are sociodemographically and racially similar. So I don't know, I'm interested to see what more things we learn about this. This is an old study, like a lot of, like 2006 is like, a long time ago. A lot of people were probably on efavirenz during this time and switching from efavirenz. And, what we know from the pregnancy data and from the advanced trial in sub-Saharan Africa is that the best way to lose weight is to be on efavirenz with TDF. And so if you're going from that combination to something else, it seems like you would be most likely to gain weight. But it does seem there's some interaction between your menopause status and your weight based on the premenopause data versus the late perimenopause data, and they're almost exactly the same proportion of the study participants. So I don't know. Their conclusion was that menopausal status should be considered in switching treatment. I don't know what you do once you consider it. Like, you sort of consider it and then you discuss it and then you move on, or do you like actually have that change your first line recommendations? Because as it stands now, first line recommendations remain the same, but I think it's an interesting thought. Then the other thing was, this is another one on weight changes. So this is looking at doravirine. So this is the OPERA cohort, US-based, 2018 to 2022, with follow-up through May of 2023. 388 people with HIV with viral suppression who changed to a doravirine-based regimen. The study population was 79% male, 33% Black, 78% with a BMI of greater than or equal to 25, so classified as overweight or obese at baseline. Of the women included in the study, which is only 21%, 70% of them were Black. So large proportion of the women in the study were also Black. Stratified by sex, tenofovir, disproxil, and efavirenz used prior to switch. And so Paul, I mean, I looked at this data, they make a couple of conclusions. They suggest that there's, overall, everyone lost a little weight when they switched to doravirine. That's that gray line. I mean, I think that is a very, very modest decrease in weight. But the gray line, I mean, I don't know that you could sell anybody anything with that type of decrease. Like, just be on this for a year and you will lose like 2% of your body weight. Like, that doesn't seem like a super encouraging thing. But the female line, which is that darker blue mixed with like hashed thing, that one shows a more significant weight loss. And keep in mind that that's only 21% of this population, and specifically overrepresents Black women, for whom the biggest impacts on weight have been associated with different regimens. But Paul also thought that the biggest effect was in those where the switch also included TDF. So when you switch to the combination of doravirine, TDF, 3TC, which is the combination Delstrigo pill, which again, it's unclear whether it's the doravirine, the INSTI, or the TDF, with I think more and more evidence suggesting that it is likely TDF, at least in combination with these other things. So again, there is a randomized control trial looking at switch through the ACTG, so that will hopefully provide us with better data to guide our decision-making around weight gain and weight loss, but and regimen components, but just another little piece of interesting data. The other thing I was just going to highlight, and unless anybody has any other comments on that, I mean, I think anybody who wasn't able to come last week, we had the weight management lecture was really fantastic and just gave lots of tools and suggestions about how to approach that. I think we still don't understand this, like the potential impact of sex and gender in these weight issues. And currently the guidelines don't have any specificity about that, but probably being more attuned to weight-related issues in the female, and in particular female Black population, makes clinical sense. But again, unclear which interventions actually modify that risk. So this is just an update on DoxyVac. So this was a multi-center 2x2 factorial randomized open label superiority phase 3 trial that looked at both DoxyPep and also the 4CMB vaccine for prevention of first episode of gonorrhea. And so at CROI in 2023, there was a statement that doxycycline prevented syphilis, which was great, also chlamydia and gonorrhea, and was highly significant and led to early stop of the study. And that 4CMB vaccine also appeared to be somewhat effective at reducing first episode of gonorrhea. But then there was this press release in May that was like, hold on, more final analysis may modify results. I think that in the interim, the UK had modified their guidelines to recommend 4CMB vaccination in this population at high risk for STIs. And so here they presented the final analysis of these results. So they saw no interaction between DoxyPep and the vaccine. So again, both groups on DoxyPep, not on DoxyPep. There was a group on the on the meningitis vaccine, who received the meningitis vaccine, and they no longer have really a statistically significant hazard ratio. So no vaccine is here in red, and the blue line is the meningitis vaccine, but the adjusted hazard ratio crosses 1 just barely. And so they no longer can we say that MenB vaccine is actually efficacious for preventing first gonorrhea infection. I think the way it was presented by Jean-Michel Molina was that maybe there's a small effect, which I think is reasonable. I think the confidence interval suggests that there might be a small effect, but if there is an effect, it is very small. And in terms of where we want to focus our energies for vaccine prevention of disease, I think a focused gonorrhea vaccine is probably going to be better than hoping that this MenB vaccine is going to provide cross protection. So that is an update to this. So it doesn't definitively show it doesn't work, doesn't really provide support for adding recommendation for its use. They did see some increase in resistance to doxy in doxy-PEP users, but also remains efficacious at preventing first episodes of STIs. So we are at, so any Liz or other STI friends, I don't know if Matt, I think I saw Liz Gillums earlier, but this hadn't really made it into our clinical practice here. So I don't think a huge change for us, but a little bit disappointing, but hopefully will lead to the development of something that's more targeted for our population. So I think we are just at the top of the hour, and so I will pause there and say thank you to everybody for coming. So, oh, and thank you, David Block, who's going to help me get rid of the balloons on my Zoom. And we'll look forward to seeing you next week. Have a great weekend, everyone.